Go. So thank you for all tuning in, and thank you, Leah, for inviting me and working with me to put together this important webinar. Important to me because it's one of my passions in helping to teach my patients new skills to understand why they have chronic pain and giving them tools that they can use to improve their experience and improve their mobility. So we're going to be talking about neuroplasticity, mindfulness, and cognitive therapy, and we'll introduce the idea of hypnosis as well, which I find very interesting and useful in practice. So here's a brief outline of what we're going to talk about in the next 45 minutes or so. I'll talk about group medical visits, which is the usual way that I present this to my patients. This is very helpful for family doctors that don't have time in a 10, 20, or even 30-minute visit to look at all these factors that are important for explaining to our patients suffering from chronic pain. And those of you that are not family doctors, it'd probably be interesting to know that what's possible in a regular family practice. We'll talk about neuroplasticity and how do we explain it to patients? How do we explain where their chronic pain comes from and how we can make it better? And then we'll get into some 3 synergistic techniques that I teach my patients to just embrace positive neuroplasticity, how we can use those things that have given you chronic pain, that process of neuroplasticity, and turn it into something positive that they can control. And the 3 techniques are mindfulness, cognitive behavioral therapy, and self-hypnosis. And then I'll turn it over to Leah because she has some great resources on the Live Plan B website connected to Pain BC. And I often refer, well, pretty well refer all my chronic pain patients to the Live Plan B website, and most of their family members who need understanding of their condition, I refer them to Pain BC and Live Plan B as well. So Leah's going to put on some poll questions because we like to get a little bit of feedback before and after our webinar, just to see your comfort in using and explaining these techniques to patients. So Leah?
Okay, that's my chance to launch a poll. So if you haven't tried a poll before, you're going to need to vote. Vote with your mouse. Here we go. Here's the first question. I'll let Dr. Wong read that out.
So how comfortable are you in discussing neuroplasticity with your chronic pain patients? So select one of the following, either very comfortable, somewhat comfortable, a little comfortable, not very comfortable, and not at all.
Oh, great. We've got some people voting. It's fast and furious. I'm going to give you a few more seconds, and I'll give you a warning before I close the poll, and then we'll share the results with you right away. I see we have a few more votes coming in. I'll give you another 5 seconds. Okay, oh, these are really interesting. Okay, here we go. I'm going to close the poll now. Thank you for participating. And here are the results. Dr. Wong, would you like to comment or read those out, or maybe?
Yeah, so actually that's quite impressive. So 6% weren't comfortable at all. So I think we're going to improve on that by the end of the next hour or so. Not very, 17%. And a little, 26%, somewhat, 39%, and very, 11%. So I'll give you a hint. There'll be similar questions at the very end, and if I'm doing a good job, hopefully we'll see more people feeling more comfortable and just starting the discussion with your patients. And if I don't do a good job, then you might not hear another webinar from me. So I'm hoping for some good results at the end.
Great. Okay, can I launch the second one now?
Yes.
Okay, here we go.
So how comfortable are you in recommending mindfulness to your patients with chronic pain? And it's okay if you don't have a lot of comfort, because if you haven't practiced mindfulness, you may not have too much familiarity, but many of you do. So select one of the following: very comfortable, somewhat comfortable, a little comfortable, not very, or not at all.
Okay, great. Looks like most people have voted. I'll give you a few more seconds. Okay, interesting. I'm going to close the poll now, so last chance. Here we go, and I'm going to share the results.
Oh, that's great. So a lot of people are familiar with mindfulness, and 41% feel very comfortable in recommending it to their patients, 27% somewhat, 21% a little, 9% not very, and 2% not at all. That's
Interesting. Well,
great.
thank you, everybody. Yeah, and before we launch the very last poll question, I should just say it's really great to see such a diverse group of participants today. So we have people joining us from primary care, allied health, and it's quite an assortment. So it's good to see that that you are also voting and sharing how comfortable you are with talking about these things with patients. So thank you. All right, I'm going to just launch that very last one, and I'll let Dr. Wong speak to that.
How comfortable are you in recommending cognitive behavioral therapy to your patients with chronic pain? Again, very, somewhat, a little, not very, and not at all.
Okay, I see the votes coming in. I love this. It keeps changing back and forth. Okay, wonderful. So this is our last poll question before we start, just to let you know. And it looks like most people have voted. I'm going to give you a few more seconds. Okay, here we go. I'm closing the poll and the results.
Good. So 26% of you are very comfortable in recommending CBT, 27% somewhat, 23% a little, 18% not very, and 6% not at all. So that's great.
All right, so now you can go back to slide view and I will let you continue there. Thanks very much.
Okay. So as I mentioned, I'm going to first talk about group medical visits, not spending a lot of time, but for family doctors that haven't experimented with group medical visits, I strongly recommend it. So I'll just give you an overview of what's involved in group medical visit, how to set it up, and then an overview of how I actually go through a group medical visit with my patients. And then the slides I'll be using for the remainder of the presentation are the actual slides I use during my group medical visits. So for those of you not familiar, a group medical visit is covered by MSP. It's a one-on-one medical care, but it's delivered with a group of patients. It could be 3 or 15 or even 20 patients. And the length is usually 30 or 90 minutes, so that's much longer than your usual visit with your family doctor. And it allows more time to discuss more complex topics. And it gives an opportunity for lots of feedback from patients and a variety of patients, so they actually help educate and support one another. So that's one of the big benefits of why you should consider group medical visits. It's that sharing of experiences, that mutual support, and really more time to discuss these more complex issues and explaining chronic pain to patients. And in particular, I do group medical visits because it's really deepened my professional connection with my patients, as it makes a huge difference for them that I've invited them personally to join a group on a Saturday morning or an evening outside of regular office practice, and just to teach them some really novel skills to improve their health. And they know I've dedicated a lot of time to put the materials together, a lot of thought into bringing them in. And I always introduce them as, I brought together 10 of my favorite patients, because they really do have a personal relationship with me. So I urge you to give it a try, maybe just 3 or 4 patients at a time, but it really makes a difference when you're able to spend that much time with your patients. So the 4 steps in delivering group medical visit is selecting your topic. In our case, we're talking about chronic pain, but you can do another condition like for your patients with diabetes or high blood pressure. But chronic pain is so complex that I thought it was really useful to bring my patients together as a group. So you select that target group. You select a time and location when you can do it. So if you have a small office, then you might have to use the reception room after other patients have left at the end of the day. You might do it early in the morning or in the afternoon. You could do it with or without your medical office assistant giving you some support. I do bring my medical office assistant, and I'll tell you how she supports me in doing that. And then, of course, you notify the patients once you set it up. And you could do that either by having a registry. That's a list of your patients with diabetes or chronic pain, calling up the people in that group, making a list of the patients over time. So that's what I tend to be doing, because I encounter patients that maybe it's been 4 months since their car accident and they're not getting better with the current techniques that we're using. And I notice that they're showing the signs and the type of thinking we often acquire when we're suffering from chronic pain. So I tell them that I'm putting together this group to discuss different techniques to help you manage with the chronic pain, including cognitive therapy, teaching you some self-hypnosis and some mindfulness meditation. Or you can my colleague does lots of group medical visits in a variety of types. So he puts a poster in his reception room and the examination rooms. So patients actually sign up with a medical office assistant. If you have a website, you can advertise it to your own patients to do. You can email particular patients, but most effective is that personal invitation from you when you're with a patient or giving them a call. I found pretty well a 99% turnout when I've offered this to my patients. And to prepare for the talk, you could use handouts, and you're free to use the handout that we've provided you. This is the actual handout I've been honing and developing for my patients through the group medical visit. So you can't absorb everything you hear in one visit. So it's something for them to take home that we follow up with later. And you don't have to use PowerPoint for group medical visits, but you're free to use the slides from my PowerPoints and to modify it as appropriate to your group and your patients. And certainly the handouts and the slides could be used for your individual patients too. So medical services plan requires you for group medical visits to have direct face-to-face encounters with your patients, so you can't do it online. And it's appropriate care that you would give for that patient's condition, of course. You're arranging for any related assessments that you might need, and you're arranging for follow-up care. So we usually follow up with the patients within a month after the visit for individual visits to see how they're managing with their individual issues, but also how they're using the skills that we've taught them during the session. We need to make a note in each patient's chart, just like you would with a regular office visit. And it's not applicable if you're getting third-party payment or anything else at the same time. So it's strictly MSP, and you need to enter the time, just like with counseling visits, in the billing window when you're submitting to MSP. I've had no problems doing these submissions, and it's quite easy to do once you get the hang of it. So in my particular group medical visits for chronic pain, the title of the visit is Mastering Chronic Pain. So it's positive and gives them some hope, and it's quite honest. We're giving them skills that have been evidence-based to improve the reduction of the chronic pain, but also to improve their functioning. So the first one I did, so I've done 6 so far over the past 2 years. So I've invited 12 patients to come in on a Saturday morning between 9:30 and 11 for a group session to teach them new ways of managing their pain. We ask them to arrive 15 minutes early so that they can complete the brief pain inventory, the pain catastrophizing scale, and the PHQ-9 to screen for depression. So this is a great time to do, rather than having the patients do it right in front of you. So my MOA gives them the handouts when they come in, gives them the questionnaires to complete, and then she puts them through my electronic medical record while we're in the visit with the patients. We also ask them to bring just a memory stick. And then while we're in the visit, my medical office assistant does a virus scan on each of them and then downloads some useful materials, including a guided meditation, some more materials on managing chronic pain and CBT, and a guided hypnotic induction, one for sleep and one for managing the chronic pain. It'll be similar to what I put them through during the group medical visit. And I really began with a personal experience with my own chronic pain, because I had rheumatoid arthritis as a child and hospitalized for a couple of weeks when I was 10 years old. So I tell them I have this experience of dealing with pain that's there every day and sometimes worse, and having that uncertainty of not knowing when it's going to end or how to control it. So that experience kind of lets you know that this is something that all of us will experience at one time, either in the past or sometime in the future. And it kind of lends a little bit of experience, but all of you, even if you haven't suffered from car accidents or chronic pains or neck injuries like I have, can understand your patients, and you have a lot of confidence from your patients because you've helped many, many other patients deal with similar conditions and dealing with chronic pain. So you have credibility even if you can't share a personal story. And then I go on to explain our current understanding about neuroplasticity and chronic pain. I review the medical evidence for mindfulness, CBT, and clinical hypnosis, and then I put the group through a guided mindfulness meditation. We won't do that today, but I'll give you a few ideas of what the experience is like. And then I go through common cognitive distortions that we experience when we're dealing with chronic pain. And I tell them that I go through those same thought process when I was dealing with neck pain after a car accident, how I tended to catastrophize or try to think about a medical cure or further interventions that I might need. I then go on to explain how hypnosis works to reinforce positive behavioral and cognitive changes. And then I put the group through a guided 20-minute hypnotic induction specific to chronic pain. And in this, I'll give an outline of what I do during this session, but I essentially help them to visualize themselves in the near future having achieved some skill in these new things they're learning with cognitive therapy and mindfulness, and have seeing themselves as being more in control of their body and their life and engaged in things that matter most to them. And then at the end, we give them that memory stick on which my medical office has downloaded the induction and guided meditations with the instructions that they use it on a daily basis, just like medication, and probably even more than medication, because we're engaging positive neuroplasticity just to create new connections between the neurons so they can create a sense of mastery and actually reduce their pain and improve their functioning. And again, we see the patients and follow up within the next month for a regular one-on-one visit. And then at those times, we review how they're managing and how they're doing with practicing these skills. And invariably, those that have been practicing the skills every day have positive effects. They feel more in control. One of my patients who had been using a fair amount of codeine every day for spinal stenosis and was on the waiting list for surgery, found that she didn't need to use her Tylenol 3 anymore. And in fact, she's decided she's not going to go for surgery, that she's actually managing well using the mindfulness, the CBT, and the hypnotic inductions. So that's a great success story. So I start off with my patients in talking about what is pain. And pain is really a normal function of the human nervous system that signals to the brain potential injury to the body. So that's an important function, so we don't want to eliminate pain altogether. And I explain that we have these sensors called nociceptors in the periphery. Like if we injure our hand or touch something hot, it sends a signal that goes up the peripheral nerves to the spinal cord, part of the central nervous system, and up to the brain. But we now know that there are ways that the spinal cord and brain change over time. And that's the challenge of chronic pain. So when pain becomes chronic, it can really affect every aspect of our lives. And you recognize this chronic pain spiral just in your patients, but it's also on the Pain BC site. So after you've had some injury and some persistent pain for at least 3 months, and if the pain is not well managed and we adopt really unhelpful pain mess and we start avoiding physical activity because of tight muscles and discomfort, and we're suffering from loss, anxiety, depression because of a loss of function or daily pain, will further reduce our activity and our social activity. We become isolated, function less and less outside of our home with work or school or relationships, and we can develop sleep problems, mood disorders like depression, and pain becomes the center of our life. So when pain does become the focus of our lives, it can really shade our emotions and shape our thoughts. And I give my patients this illustration. When we're anxious, it changes how we think. We overestimate the danger or challenge before us, and we underestimate our ability to manage. And when we're depressed, like Eeyore, we think negatively about ourselves, our situation, and our future. I use this slide to describe this simplification, the triune brain. So it's kind of a simplification, but it tells us that our brains have evolved, but we hold within our brain important functions that come from our evolution. So in our brainstem, in our cerebellum, we can call that the reptilian brain. And that's important for avoiding danger, for basic needs, hunger, survival. So when we're faced with danger, we activate that reptilian brain. And that's still important for survival today. The limbic system, or the emotional brain, is sometimes called the early or pre-mammalian brain, or paleomammalian brain, and that's involved in feelings and emotional reactions and connections. And then there's the neocortex, that's the higher primate brain, and that's involved in our rational thinking brain. I use this to illustrate because our emotions are an important part of our survival. But when we're activated by severe pain, chronic pain, and strong emotion like depression, anger, severe anxiety, we really engage that limbic early mammalian brain. It kind of takes over our thinking, as we saw with Rabbit, who was anxious, and Eeyore, who was depressed. That really narrows our thinking. And it can lead us into a cycle with cognitive therapy where negative thoughts beget negative emotions and in a vicious cycle, and then actually worsen our chronic pain. And we're going to learn some techniques in this group medical visit with our patients in engaging the neocortex and using other parts of the brain with mindfulness, cognitive therapy, and positive visualization. So we can get out of that getting engaged in the limbic portion of the brain, acknowledge those emotions, but learning how we can manage and control and master them, and therefore master our pain. I put it to the patients, aren't you curious of why, even though the injury happened quite a long time ago, 3 months, 6 months, a year, or 10 years, even though the tissues have healed, why is the pain getting worse? So it kind of hints that something else is going on. And it's really important when we're talking to our patients individually and when we're in the group to explain to them that we do believe you, we do know you're in pain. And just because we're talking about techniques that can improve it, that engage different parts of the brain, does not mean that the pain is all in your head or the suffering's all in your head. And it's certainly not your fault that you're suffering from pain. It's not doing from something that you're lacking or a lack of effort. So that's an important message when we're talking about neuroplasticity, because we want to take the blame out of it. We want to engage them, and we don't want them to think that it's all in their head. So we need to take that time to explain. And doing it in a group is a good way of doing it, because we'll have patients with various levels of understanding and various experiences with chronic pain. And a little bit later, I'll tell you just an example of what a patient said who had really been on the mastery side of chronic pain and what she shared that really engaged the group. So again, make sure your patients know that you believe them, that we know that it's not in their head, although we're going to teach them skills to engage their nervous system to improve their coping with pain. So we'll tell them about the power of neuroplasticity, that neurons that fire together, wire together. And this is a quote from Donald Hebb. So he was a Canadian neuropsychologist from, I believe, McGill. And he was a pioneer in neuroplasticity. And he told us that this is how our brains learn, that with habitual thoughts and connections between neurons, those connections become stronger over time. They become almost hardwired. And that's why with chronic pain, the nervous system gradually becomes rewired to increase that pain. The neuronal pathways that conduct pain from up the spinal cord up into the brain become entrenched and supersensitized, and the structures of the brain actually change to accommodate pain. So we become more sensitized in that area that's been injured, and it could generally increase our sensitivity to pain overall. That's why you might notice a lot of your patients might morph from having a specific injury after an accident to fibromyalgia-like symptoms. So I show this to patients just to explain that even though the number of neurons in your brain and spinal cord don't increase over time, their connections can change based on learning and our experiences. So neurons are connected through synapses. So we have these axons, the extensions of nerves. They can sprout extra axons over time. So we can reinforce things. The experience of chronic pain increases that connection and reinforces it, just like a well-worn path. So this is the nature of learning with habits, where you don't have to think through how you're going to get into your car and drive home. You don't have to relearn how to swim or to ride your bike again. You just go into that familiar pattern, and that can work for the positive things in human learning, but it can also work for negative things like bad habits like smoking or overeating or drinking, and also the experience of chronic pain. I don't go through a lot of detail with this, but it shows to them that we have networks in our brains, the connections between neurons and actual structures within our brain, in the limbic system, in the prefrontal cortex, in the brainstem and cerebellum, that are sensitized to two types of experiences of pain, the sensory itself, and also the affective or mood and cognitive or thought aspects of pain. I show them the image of the somatosensory cortex, the portions of the brain that are involved with sensation in different parts of the body. So we all know that there are larger areas of the somatosensory cortex in the brain that are dedicated to the more sensitive areas of the body. So if we want more sensation around our eyes and face and mouth and lips and tongue, a fair amount in our fingers and our hands, much less in other parts of the body, including the lower limbs and your little toe. So different areas of the body have a different representation in the somatosensory cortex based on the sensitivity. And what happens with chronic pain is that area that you've injured, it could be your left foot or your great toe on the right that's been injured and becomes the focus of chronic pain. And that area changes the brain so that a larger area of the brain is dedicated or will emphasize pain experienced in those areas. And then this is just a reminder that pain is an integration of sensory and emotional experiences. So it's not imaginary in the fact that it's not in your head, but it is part of how the brain changes without us consciously doing it. And this is, again, part of how the brain functions. And this is the most important thing, that we can use this normal human property of neuroplasticity to master your pain. So in the same way, we can reverse the process and transform those neuronal pathways. And I use 3 mind-body techniques that have been shown through evidence to transform the brain, as seen in functional MRI and outcome studies on patients' function, how we can change the nervous system and reduce pain and the associated suffering. And of course, these are mindfulness, cognitive behavioral therapy, and clinical hypnosis. And the hope is that we can bring you back to a life that had been pain-centered with this understanding, education, increased activity, improved cognitive function, and learn skills and feeling engaged and back to your function-centered life, doing the things that matter most to you. So I've introduced mindfulness. So to a lot of people, mindfulness is a popular term, and many of us understand it at many different levels. It's popularly known of as a form of meditation and is in widespread use in the management of pain, stress, depression, and anxiety. John Kabat-Zinn at Harvard Medical School really was a great proponent, both in his popular books like Calming the Mind, Wherever You Go, There You Are, Full Catastrophe Living, that he wrote on the use of mindfulness, and also his evidence-based studies that showed improvements with cognitive-based mindfulness or mindfulness-based cognitive therapy to improve stress management in a variety of conditions, including managing cancer pain. Its origins are from Buddhism, and you might think of the Buddha as one of the first psychologists who kind of came upon how the brain functions. And it's popularized by Thich Nhat Hanh and the Dalai Lama, and they write many, many popular books on the topic more from a religious perspective. And it's used in a secular, non-religious form by psychologists, physicians, and other healthcare professionals like yourself. Rick Hanson in particular is a neuropsychologist, and he has a great website, and he's written a number of books that really explain to the public how these techniques, the techniques of mindfulness, have been shown with functional MRI and shown with numerous studies that we're actually changing the brain and improving how people feel, improving mood, and improving chronic pain. So a great book to recommend to your patients is Buddha's Brain, The Practical Neuroscience of Happiness, Love, and Wisdom. And in this book, he actually outlines some really useful exercise and then the evidence for how it works and how it functions and how many people have found improvement with it. So that's a good one that I recommend that you take from the library, have a good look at it, and if you agree, you could recommend it to your patients. Now, though it's popularly thought of as simply being present in the moment, with focusing on the breath and physical sensations, if you really practice it every day for a period of time, and really serious practitioners of mindfulness may do it 1 or 2 hours every day. My aunt, who is a practicing Buddhist, does it 6 hours out of the day, and it's really helped her to cope with all the challenges of getting older and dealing with chronic illness. And with practice, if you practice regularly, you learn to experience all phenomena, just not your breath and physical sensations, but also sounds and sights, smells, thoughts, and feelings without judgment and without identification. So being less reactive to everything. So at this point, I introduce a guided meditation, and I can give you just kind of a 2-minute idea of what it's like. So those of you that have not practiced a bit of mindfulness. So wherever you go, so I'm assuming you're not driving a car, but sitting hopefully at your desktop, I'd like you just to close your eyes and just be present and notice the sensation of your body, where your parts of your body are just contacting your chair and the floor and your shoes and your clothing. And just notice how those different parts of the body feel. The sensation of pressure or hot or cold or tingling in different parts of your body. And you could bring your attention to just one small part of your body, and that could be the fingertip, the index finger of one hand. And just notice the sensations that you feel in that fingertip that you didn't notice a moment earlier. It could be a little vibration, sense of warmth or coolness. And this is an important thing to teach our patients with chronic pain, that they could be present with an area that's causing some discomfort, but when it becomes too uncomfortable, they can shift their attention to another part of the body that feels kind of neutral or comfortable, like the tip of their little finger. Another anchor that you can focus your attention on now is just your breath, just the sensation of breathing in and breathing out, not trying to control it in any way, but just take a moment noticing what it feels like and where you feel it most in your body, perhaps your nose or your throat, in your chest. Where do you feel that breath coming in? And where do you feel it in your body as you let it go? So spend a moment just noticing the breath and using that as your anchor. So if thoughts or sounds come into your mind or awareness, gently return to the anchor of your breath, the sensations of breathing in and breathing out. Now turn your attention to the sounds around you, perhaps sounds in the distance, perhaps just the sound of my voice or the sound of your own breathing. Just let those sounds come into your awareness just as they are, without labeling or identification. Just experience sound just by itself. And if your mind wanders to different thoughts, just return to the soundscape, the anchor of your ear. And now let's just return just to your regular awareness. That was a very, very short mindfulness meditation. And to really get the most out of it, you do it for at least 10 or 20 minutes. And in the references that I give with my patient handout, there's references to tarabrock.com. So Tara Brock's a psychologist that has a lot of resources for learning mindfulness on her website. So she has lectures or talks that she gives at retreats, but also a lot of useful guided meditations. So if you'd like to get more practice or have a way to, you want a way of teaching your patients mindfulness, you could do a guided meditation with them, or you can refer them to Tara Brock's website, and it's all free. So the practitioner develops a deepening concentration and awareness. So mindfulness becomes not just meditation, but changing your experience of life itself. So with time, you recognize that mindfulness means that all things are impermanent. Your thoughts, your feelings, even your pain. And we learn to experience things without reacting to it, without identifying, and decreasing our resistance. So identifying means taking ownership of it. Because usually when we're dealing with pain, it kind of grabs us, it becomes part of our identity, especially when it becomes chronic. When we're angry or upset, we actually label ourselves and the emotion together. I'm angry, I'm sad. And that makes it harder to let go of it, becomes part of our identity. When the reality is our emotions and our thoughts and our sensations are changing moment by moment. So when we're mindful, we're not carried away by our emotions or our ruminations, like lost in a train of thought. And we recognize that our suffering comes from our reactions to phenomena. It's either aversion or craving. So aversion is reacting with anger or fear or hatred, or craving is desire or thirst or clinging. So we tend to have aversion to things that we don't like, unpleasant sensations like pain or strong emotions, and craving or clinging to the things that we do want. And that actually causes most of our suffering, because if everything changes, we can't hold on to them. But if we react with aversion, we create more suffering. So in mindfulness, we talk about the two arrows. So the first arrow is that sensation, that feeling or the thought. But practically all our suffering comes from the second arrow. And that second arrow is our reaction to things and our resistance. So one Buddhist teacher, Shinzen Young, came up with this formula: suffering equals pain times resistance. Kind of giving that thought that if you had no resistance to whatever arises, you would have no suffering. And really the goal of mindfulness is equanimity, to be empty of that ego, that little self, that little story that we kind of create when we're in negative hypnosis, when we're in the trance of everyday life. So we'll talk about that later when we talk about hypnosis. And learning to accept things unconditionally. And this is aligned with that key quality of mindfulness, which is compassion or unconditional love, what we call metta. So we are much happier when we accept others and ourselves with both compassion and without judgment. And actually, these are at the core of what we do in healthcare. So it's kind of part of traditional medicine that we treat our patients with compassion, unconditional positive regard. And all of you that are physicians, family physicians, and healthcare providers, you have this compassion. That's why you're in this field. But particularly in family practice, we are with our patients. We understand their suffering, and we want what's best for them. But also we must have equanimity. Otherwise we can get carried away or reactive to things. So William Osler, the most famous Canadian doctor from McGill University, really emphasized that importance of equanimity, to have good intentions, to do our best for our patients, but to know that things will not always go our way, and to have equanimity with that as well. So I teach my patients this traditional metta meditation. How do you actually teach unconditional love? Because when you think about it, most of our love is conditional. You love your children, we think unconditionally, but you love them because they're your children, not the neighbor's children. But this is a practice that we can use to kind of expand your compassion towards other people, even people that seem to be more challenging in your life. So just visualize someone in your life that you naturally love and feel happy when, bring a smile to your face when you think about them. So visualize that person and wish these four things as you see them. May you be happy, may you be healthy, may you be peaceful, may you be safe. May you be happy and healthy, peaceful and safe. And if you do that for 5 or 10 minutes, you'll find that your feelings towards them are even more deeper, more compassionate. The next step in that meditation is to visualize someone that you don't know very well, someone that you've never had a conversation with, but someone that you see every day. Maybe the barista at the coffee shop where you buy coffee to that you haven't really gotten to know. So you're kind of feeling neutral. You don't dislike them, but you don't know too much about them anyway. And you could do this practice, visualizing them in your mind's eye, and just for 5 minutes every day, wishing them happiness and health, peacefulness and safety. May you be happy and healthy, peaceful and safe. And I guarantee if you do this for 10 or 15 minutes every day for a week, your feelings toward that person will become more compassionate and more loving. They become an object of your unconditional love without them even doing anything to deserve it. And that is nurturing unconditional love. And the challenge is to imagine an unpleasant politician in another country that you don't like and wishing them happiness, healthiness, peace, and safety, or at least wishing them equanimity and freedom from anger and hatred. So that'll be your challenging exercise. The RAIN acronym, I'll just touch this briefly because you'll have the slides in the reference to Tara Brach, but RAIN is an acronym about how we approach pain, suffering, and emotional things that we're meditating upon. First, you recognize what is arising, not ignoring it. Allow it to be, just as it is. Investigate just what it feels like to be in your body without ruminating upon it. What's going on? What am I feeling in this part of my body? What do I need to accept? And then N is non-identifying it. Not having your sense of being defined by any emotion or sensation, not taking it personally, and bringing to it some compassion. So if you're dealing with fear, bring some compassionate love to it as a kind, loving parent would, that you're okay, that you're safe, and this feeling will soon pass. So that's the RAIN acronym. Now on to cognitive behavioral therapy. So I explain to patients that how we think affects both how we act as well as how we feel. And how we feel, as we saw with Eeyore and Rabbit, anxiety and depression can influence how we think. It can narrow our thinking and it affects our behavior. So when we're depressed, we withdraw and we don't feel like doing things and socializing and doing things for ourselves. We just want to stay in bed. And if we're really anxious, then we'll avoid the thing that's causing anxiety. And our behavior, what we do, affects how we think and feel, and it's used in psychology as well. So in dialectical behavioral therapy, we have the action urge for depression is to withdraw. So what you want to do to improve your depression is to get out and do something, even if you don't feel like it. And what the action you should do if you're anxious is to gradually confront the thing that causes you anxiety, and this changes your feelings too. And our behavior changes how we actually think as well. So in any situation, we can use mindfulness to bring our thoughts to what am I thinking? What's going on in my mind? What am I feeling? What's my body feeling? What sensations do I experience? And what am I doing? So this in itself can be a meditation. When we're aroused by pain or a red light or a difficult situation, ask yourself, what am I thinking? What am I feeling emotionally? What am I feeling in my body? And what am I doing? And this slide is from mindfulness.org or Mindful Magazine. And it just reminds people that thoughts are not facts. Your thoughts are true in the sense of that's what you're experiencing right now. But you can kind of question, is there another way of thinking about the situation? And how do my thoughts, how do they affect how I feel? And I give my patients this handout on unhelpful thinking styles, or what we call cognitive distortions. And then I go into each of these to explain. A common one is emotional reasoning. So these are things we all do, but they can really affect how we feel about things. So emotional reasoning is inappropriately reasoning from how you feel. So if I feel something bad will happen, I really believe that something bad will, just because I have that feeling. Fortune telling is assuming that you really know how things will turn out, and we don't know. But it's thinking, I'll always feel this way, I'll never get better. Mind reading is a cognitive distortion where we're believing you really know what another person is thinking. And we commonly do this with our friends. I know when my friend didn't call me back. We make assumptions by what they texted, or if they don't answer a text, we make huge assumptions pretending that we're mind reading. And 50% of the time, we're wrong. And if we're really depressed or anxious, then 80% of the time, we could be wrong. Overgeneralizing is making broad assumptions based on the facts at hand. Like all doctors are quacks. You might have encountered one quack, but then you assume that all doctors are quacks, or that no one cares about you. So a broad generalization that just makes us feel more hopeless and more helpless. Polarizing is all or nothing, black or white, or good or bad thinking, and we all do this at times. She used to be an angel, now she's like totally evil. Either you're with me or you're against me. And shoulding means inappropriate judgment, and we all do this, especially on ourselves, and we do it to others as well. Like, I have to be perfect, and a lot of healthcare providers, especially doctors, have a lot of this underlying perfectionism. I have to be perfect in order to be loved, or to be good, or to be a good doctor. Personalizing means taking things too personally. He did that just to hurt me. And catastrophizing is believing the very worst things are going to happen. I'm going to fail, I'll never be a success, or this is the end of the world. So in particular, I talk about the common negative thoughts about chronic pain. So these are the cognitive distortions that those of us that have suffered from chronic pain have had pop into our minds. And sometimes we can ruminate upon them and they make us feel much worse. They actually increase our anxiety, depression, our pessimism, and pain itself. And again, we see catastrophizing, imagining that and expecting the worst possible outcome. The pain will always be here. The pain will just get worse. The pain controls my life, and I will never get better. Harm beliefs, believing that pain always means harm. So pain means that I'm causing more harm to my body. So you see that in your patients, they're afraid to move or turn the neck or do more exercise because they believe that activity will cause more pain. Medical cure beliefs, the obsessional hope for a cure. So when I had a neck injury, I asked for an MRI. I had a colleague inject a steroid into my facet joints. I must find the medical cure, medication, or procedure for my pain. I need to see another specialist. It's the responsibility of healthcare providers and not me to manage my pain. So at some point, we have to realize that we've done enough investigation. So once we're reasonably sure that we've gone through a good workup and ruled out that there are any underlying serious conditions or things that we can treat or cure, then we're able to use these tools to cope with pain. And then chemical coping that we all use from time to time. It's using drugs or alcohol to stop the pain, prescription or non-prescription. Kinesiophobia is the fear of movement. Movement causes pain, or I have to lie down or sit down when I have pain. And then disability beliefs. I am disabled by pain. I cannot live a normal life because of pain. And then we turn things around that these are the adaptive thoughts about pain that have been shown to reduce anxiety and hopelessness, and they empower us. And they not only can improve our functioning, but to a large extent, it can improve our experience of pain. So the first is self-efficacy and a sense of control. I have the skills and resources to manage the pain and its effects on my life. Acceptance. I can accept this pain, but I choose to remain engaged in what matters most to me. De-emphasizing pain. And this is a quote from one of my patients at one of our group medical visits. And she told the others that pain is no longer in the foreground of my life. It's faded to the background. And pacing. I can maintain an appropriate level of activity, not too much and not too little, even in the presence of pain. Perseverance. I will not allow pain to interfere with the essential activities of my life. Exercise and mobility. Daily exercise helps me remain fit and strong. Reminding our patients, keep calm and review your cognitive distortions. And it's not your fault you have these. These are the traps all our brains fall into. But actually turn your thoughts towards these more positive thoughts to try them on. You can read these in your slides and in the handouts, but these are ways of challenging cognitive distortions. And a good way is just to ask yourself, is this way of thinking helpful for me? Is it this another way of looking at things? If my best friend or loved one heard me talking this way, what would they say to me at that time? Don't believe everything you think. Now we'll talk about hypnosis or trance briefly. So trance, or the hypnotic state, is actually an altered state of consciousness marked by dissociation from normal awareness and a heightened level of suggestibility. It's actually a natural state that you fall in and out of every day but don't realize it. When you're watching a movie, engrossed in a novel, madly in love, following a really engaging webinar, lost in thought, or just caught up in our ruminations. So you were in a trance when you were in an impressionable toddler and a child during really emotionally charged experiences in the past, or when you're in new places like on vacation, really engaging your senses, and of course when you got married. At those times, you may have accepted incorrect beliefs about the world, other people, and yourself, like I have to be perfect, or I'm not good enough. So these things that we acquired when we're younger may or may not have been stated, or something that we assume, but we've reinforced subconsciously over time. And they really influence your worldview and how you tell your personal story. So that trance is sometimes referred to as the default mode, where we actually make sense of things and get caught up in our stories. Therapeutic hypnosis or clinical hypnosis is actually therapeutically inducing this dissociated state while remaining conscious. So we're engaged in the subconscious and make it more open to suggestion, and allows us to reinforce these positive adaptive thoughts that we just talked about and reinforce positive emotions and positive behavior. Really, you could teach your patient self-hypnosis. We allow the conscious mind to relax and engage the subconscious mind with imagery, so sounds and sights, sensations. And we often start with deliberate relaxed breathing and progressive muscle relaxation. So it sounds a little bit like mindfulness, but it's different. We're actually suggesting that we're breathing in relaxation and breathing out tension. And as we're breathing in and breathing out, our muscles are relaxing, kind of creating that sensation and imagery. And we might imagine going down a magic escalator or down a magic elevator, and as we go down, we go deeper and deeper. And then at this point, we can give positive suggestions to our subconscious. Really, we're creatively visualizing the goal. So engaging all of our senses. So I usually bring my patients to a scene at a pond in a beautiful garden and seeing their reflection in the near future as they would like to be. Seeing themselves engaged in all the things that give meaning to them and not being disencumbered, not being held back by physical discomfort. At this time in the near future, they've mastered these cognitive skills and mindfulness and see themselves achieving their personal goals and potential. So I learned clinical hypnosis in my first few years of practice, and I found it really was a game changer in my relationship with patients. Because when our patients are with us in emergency or just during a regular visit, particularly with kids, they're really in a trance state and heightened suggestibility. So what we say to them has a huge impact on how they see themselves or their illness. And for this reason, I think all healthcare providers should learn a bit more about clinical hypnosis, how they can not use it negatively and intentively, but actually use it in a positive way to reinforce positive skills. So if you want to learn more about hypnosis or learn about practitioners in your area, go to the Canadian Society of Clinical Hypnosis website. And every year in February, we do a 2-year training workshop for healthcare providers. And that could include psychologists, clinical psychologists, social workers, doctors, dentists, and a variety. If you're not sure if you qualify, you can contact the Hypnosis Society in BC. So I'll be teaching at the next workshop at SFU's downtown campus in February. So putting it all into practice, with these 3 tools, we're teaching our patients mindfulness, CBT, and self-hypnosis. We can really regain our sense of control, transforming their helplessness and hopelessness into engagement and empowerment. But the essential key to really embrace that neuroplasticity is daily practice, to reinforce those new neural pathways that we're creating so that those neurons continue to fire together and wire together, because we're really creating and reinforcing new pathways. So I ask my patients to take 10 or 20 minutes each day to do mindfulness meditation, either on their own or with the guided mindfulness meditation on the USB stick or with Tara Brock's website. I ask them to listen to a mindfulness talk each day that they can find on the web connections that I give them on a handout, and adopt that mindful perspective in everything that you're doing. It's really informed my practice where I'm totally focused on my patients when I'm with them. And really accepting everything and everyone without resistance, but loving kindness. So we're really recognizing mindfulness of our thoughts and emotions. Let our thoughts and emotions and pain be our mindfulness chimes. Recognize unhelpful thought distortions, and with kindness, replace them with empowering adaptive thoughts. And then with creative visualization, self-hypnosis, we can replace those unhelpful core beliefs with positive, empowering beliefs about ourselves, and really experiencing your future self, really a blueprint for achieving mastery. So really see the goal you want to achieve. Be an agent of positive change in your body, in your own life, in our community, and in our world. So this is what we want to do ourselves, to be agents of positive change in the lives of our patients, and teaching them to be agents of positive change with their own bodies, with their own life, and in their own community and life too. So Leah, I've gone over time, and I know you want to do another poll and introduce us to those wonderful resources on Live Plan B. So I'd like to turn things back over to Leah.
Hi, this is Jen Hansen. I'm also with Pain BC. Leah's actually had some technical problems, so I'm going to take over for her in the last couple of minutes. So I'm just going to quickly see if I can do this poll here. Do you see it after this webinar? Dr. Wong, do you want to read this?
Certainly. So I hope we do well with this so that I'll be invited back. So after this webinar, how comfortable are you talking to your patients about neuroplasticity and recommending mindfulness and cognitive behavioral therapy?
And I'll just give it a couple more seconds, and I will close the poll. But I can tell you in preliminary results, we have, I can see some improvement here.
Oh, good. So I will be coming back then.
Okay, close the poll in 5 seconds. And closing poll and sharing results.
Oh, that's
It's looking
great.
good.
That's great. So 45% very comfortable and 48% somewhat comfortable and only 8% a little. And no one said not very or not at all. So thank you very much for um, your engagement, and encourage you to continue with our handouts. Now, do we have time for some questions?
Well, there's 2 here, and I think they're pretty good. So if we could just quickly go to them. So someone is asking, she says, I'm not sure if I can, like, it's very good. I'm not sure I can run this teaching myself. What resources are available other than books that she can refer patients to, or even get,
Okay, great.
you know, other courses?
Great question.
That provide, yeah.
Yeah, so I wouldn't expect most people feel comfortable for doing the whole thing, because very few physicians obviously do teach hypnosis. And more physicians are learning about cognitive behavioral therapy. Mindfulness we're all familiar with. So I invite you to look at the patient handout, because it actually has resources for where they can go to actually learn about mindfulness. They can go to the websites. There's a number of books that are great for an introduction to mindfulness. Particularly the way I taught it in this group workshop is how they can introduce it to their patients and how they can practice. And there's a local group that's also on the handout that has mindfulness retreats on weekends out at UBC. So guided mindfulness retreats, which is great. Cognitive therapy, there's a variety of resources also in the handouts. And physicians can get training through continuing medical education. It's taught through PSP. Adult mental health module. But a great resource is CBT Canada, where I learned cognitive therapy from Greg Dubourg, a psychiatrist. So it really shows you how to use CBT in 10 or 20 minutes visits with your patients, getting them to do most of the homework. And one of his sayings is, don't work harder than your patients with CBT. And if you want to learn about more hypnosis or know who to refer to, check on that link to Canadian Society of Clinical Hypnosis BC Division. If you want to learn more about training yourself, or you can contact me, or you can just see which physicians or psychologists in your area do self-hypnosis or teach clinical hypnosis. And we have another question.
Great. Well, thank you. Well, you know what? I actually think you answered both questions, because the other one was, do you have a list of mindfulness and meditation groups where we can refer patients to? But I understand those are in the handout.
Okay, great. Well, thank you very much. Thanks, Jen, for stepping in and helping us out. And thank you all for listening in.
Could I just add one thing, is that I know Leah was going to show some pages, the articles that you had written for Live Plan B. So I've just put the links to those in the chat. So in your control panel, if you click on the chat tab, you can see that there's 4 different articles on Live Plan B, which is Pain BC's free chronic pain self-management website. All 4 articles by Dr. Wong are there, and they're free for patients and providers to use. So thank you so much for joining us today, to all the participants, and Dr. Wong, thank you so much for your expertise today. We really appreciate it, and I think we sure got a lot out of today's session.
Thank you, Jen. It's been my pleasure, and thank you all for listening in.
Okay, well, we hope to see you again at next month's webinar. Thanks for joining.